again, and today we'll continue with the MRI imaging. And today my topic would be basics of image
sir.
formation in
Wait
MRI.
for 1 minute only.
Sir, just a minute. I think some technical issue.
Okay. So today technical issues shifted there.
Just 1 minute. I think he has not
Okay,
made
okay.
it live.
Not
Yeah.
a problem.
It is not yet live. Okay, it is done live. Now we can start.
Okay. So
Okay,
good afternoon once again. Today we'll continue with the MRI imaging, and today my topic would be basics of image formation in MRI. In last lecture, something is held up from your side or what?
Also,
Yeah. So last time we discussed the basic principles, how you get the FID, how you get free induction decay, and we discussed about the Lama frequency and the resonance frequency omega naught is equal to gamma B naught. And we also discussed that this resonance frequency is directly proportional to the applied field. And we also discussed what is the resonance frequency for various nuclei of biological interest, starting from hydrogen, fluorine, sodium, phosphorus, and carbon-13. And then we also discuss how you can apply a radio frequency energy to this system and acquire a signal through electromagnetic laws of induction. You get a time varying signal, which is called free induction decay. Now question is, the FID, this free induction decay, whether you take a sample from the brain or from the toe, it is going to be the same. So how do we distinguish different parts of the body or within the organ? Suppose we are talking of brain. How do we distinguish different areas in the brain through MRI imaging? So it's called spatial. It's a problem of spatial localization. So what we do, to do the image formation, we have a concept of gradient magnetic fields, and we apply these. There are three gradient magnetic fields applied in three different orientations, which are orthogonal to each other. These are called X, Y, Z gradient magnetic fields, and they are termed as slice selection, frequency or readout or phase encoding. So these are the three gradients which are necessary to encode a signal from a single point. So it's like, when three planes cut each other, there's a point of intersection. Similar ways, when these three gradient fields cut each other, you have a pixel, the pixel element or the image element or an image point in the to acquire. So so what happens? Gradient is basically a you do a deliberate attempt to vary the magnetic field across the axis by applying a gradient magnetic field which varies with distance. So in this picture, you can see we have applied a gradient. You have a static magnetic field V naught, which is uniform all throughout. So over that magnetic field, you apply one more field which is varying with distance. So what happens? Here you can see here in this axis 1, 2, 3, 4, 5, 6, 7, 8, 9. So magnetic field is increasing in this direction. It is decreasing on the other direction. And at the zero, which is called the isocenter of the magnet, the magnetic field remains the same as it was earlier. So what will happen? All these points 1, 2, 3, 4, 5, since they have now different magnetic fields, they will experience different resonance frequencies or the Lama frequencies depending on the magnetic field they are experiencing. The nuclei which are present in these locations, they will experience different magnetic fields, and hence their Lama frequencies or the resonance frequencies will be different. So idea is to purposely vary the magnetic field across the axis, and this concept came from the concept of chemical shifts, where the hydrogen atom and hydrogen nuclei, when it is sitting in different chemical environment, they have different chemical shifts, and hence the resonance frequencies. So this concept has come from chemical shifts. So this is how you make deliberately magnetic field different at different locations across the body or across the slice or across the sample of interest. So for more elaboration, what we have done here, we have these two test tubes which contains water. If you take a FID signal from this test tube, when there's no gradient magnetic field applied, you will see a signal peak, which will be a sum of the signals from the two test tubes, because both the test tubes are seeing the same magnetic field. So you have only one signal. Suppose I apply a gradient now, I make magnetic field in this test tube different than this test tube, then I am having two magnetic fields. So they will have two corresponding frequencies, and you can see two peaks from these two test tubes. So now we have distinguished two test tubes based on the on application of the gradients. We can extend this analogy to this phantom, hydrogen water phantom, which is a big cylinder with water. And if I don't apply any gradient magnetic field, you will see only one single peak from this whole phantom, from the whole body. You will see only one peak, which is corresponding to the hydrogen. Now if I apply a gradient magnetic field, I make this field, this V naught, varying from left to right, and then you can see I made 1, 2, 3, 4, 5, 6, 7, 8, 9 compartments. You can see there are 9 FID signals coming from this phantom now. So that means I have cut this phantom into slices, and each slice is giving me a frequency which is different from each other. So this is the basic concept of gradients. How you apply gradients, they make the magnetic field differ from on each location, so that their corresponding resonance frequencies are different, and they can be distinguished when you are performing the MR imaging. Is that clear till now? Hello?
Yeah. It's
Out?
okay, fine. Yeah.
Okay. So now same we are applying a gradient magnetic field. This is the body. This is a person, say lying position. You can see when you apply gradient field, you can make some spins to move faster, some to move slower, and accordingly you will have different in this body. You can have different locations, the spins with different resonance frequencies, which can be picked later by different techniques. So now coming back to imaging gradient, as I said, you have to apply these things to form an image to get a pixel-wise information. There are 3 identical and orthogonal gradients which are applied in X, Y, and Z direction. And I said nomenclature is a slice selection gradient. When you apply the first gradient on the image, this is called slice selection gradient. The role of this gradient is to select the slice, a particular slice in the body. You can select it anywhere in the body, wherever you like. Suppose if you are doing a brain, you can set it across the nose bridge, and then take a slice there. Then the 2 other gradients will be also applied at different time periods, and these are called frequency encoding or readout gradient and phase encoding gradients. So these gradients change their role according to slice orientation. So if Z is working as a slice selection, then X and Y will work as a frequency encoding and phase encoding. If Y is slice selection, then X and Z will work as a phase encoding and the frequency. Accordingly, they will keep changing. The first slice gradient is always applied to cut a slice. This is for sure. First of all, you have to cut a slice from the body. So the first gradient which is applied is called slice selection gradient, and subsequently phase encoding and frequency encoding gradients can be applied. So this is how these gradient coils are placed in the magnet, and you can see the orientation of the 3 coils, X, Y, and Z. And this is an insert which goes into the magnet, and then the different amount of currents can be made to flow through these coils to produce these gradient magnetic fields. So for the people who are not aware of the medical terminology, we have in medical technology, we'll always talk about axial slice, sagittal slice, and coronal slice. What it means is, if you cut a body from front to back, we call it coronal slices, which is shown here. This is a coronal slice here, and you can see we are cutting the slice from front to back. If you cut from head to toe, if you cut a slice, this is called axial slice. So you are cutting slices perpendicular to the body. And then if you cut from sideways, left ear to right ear or right to left ear, this is called sagittal plane or sagittal slices. And when you apply any of these gradients, slice selection gradients, you also apply a RF pulse which was, actually the band of frequencies which are contained in this gradient magnetic field, the net gradient magnetic field experienced by that slice. So you are applying a frequency of that slice only. So what happens? Only this slice which are applied now will be excited. Will be, you put a 90-degree pulse. Only if, nuclei in this slice will be oriented to XY plane. Okay. So as I said, when you apply one gradient as slice selection, then two other gradients work as phase encoding and frequency encoding. Suppose you want to cut an axial slice, then Z is the orientation of the slice selection gradient. Then X or Y will work as a phase encoding gradient or the frequency encoding. This is the choice. You can make any one of the two to work as phase encoding or the frequency encoding. When there's a slice selection is X, then Y or Z will be a phase encoding and frequency encoding. And when you are selecting a coronal slice, then X or Z can be a frequency encoding or the phase encoding. And one thing I want to make it clear that these three gradients are exactly identical. There's no difference in the the design and their orientation is different, but otherwise they have same capability all throughout. So now here I am showing I have applied this radio frequency pulse to a with the gradient isocenter. You can see only center slice. Here you can see all the arrows are from left to right. Only one arrow is up to down. That means only this slice has been excited using this RF pulse. Only this slice is excited by 90-degree pulse. Rest whole body is silent. There's no excitation on rest of the body. Only one slice has been selected to produce a signal. This is again depiction. Then you have a gradient here, and you can see this slice has been selected, and accordingly you apply this radio frequency pulse, and you select a slice, this yellow slice which is shown in yellow color. This slice has been selected by application of this gradient and the radio frequency RF pulse, 90-degree RF pulse. Now I can do also multi-slice excitation. If I have I want to excite 10 slices or 3 slices, I know the frequency of each slice, magnetic field, I know the magnetic field of each slice and their band of frequencies they contain. I throw three RF pulses, 90-degree pulses, so I can make 3 slices excited. You can see the rest of the body is all left to right arrows. Only these slices have been oriented to XY plane, XY axis. So now I can acquire signal from these 3 slices easily. So this is showing, this is the isocenter. This is the same frequency. And when you come forward, the frequency is increasing. When you go backwards, frequency is increasing. That means magnetic field is increasing in outward direction and it is decreasing in the backward direction. You can see how slices can be, selected out of the volume. Now, after you have selected the slice, now you have cut a object. You have cut a 3-dimensional object and made a 2-dimensional slice. Now, on this slice also, all the picture elements have the same frequency and phase. So I cannot distinguish them from each other. I have to distinguish each point in this space, in the 3-dimensional space. So what I do, I apply a frequency encoding gradient in the X direction. And then I apply also a phase encoding direction in the Y direction. So what I am doing now, this pixel which is shown here, it has a specific frequency and a phase combination. And on this column, all pixels, they will have same frequency, but they will have different phases. Is it clear? This pixel now, after I apply these 2 additional gradients, the phase encoding and frequency encoding gradient, I am making this pixel to have unique frequency and phase combination so that this pixel can be distinguished from all other pixels in the image. Similarly, if you see, look at this now, I have selected 2 pixels now, pixel A and pixel B. Pixel A and B have the same frequency, but they are different phases. Like this has omega frequency, but phase is phi B. This has omega frequency, but phi A. So these 2 pixels are completely distinguishable on the basis of their frequency and phase combination. Similarly, on this vertical column, all pixels on this column will have same frequency but different phases. And similarly, on this horizontal column, horizontal row, they will all have same phase, but the different frequency. So all the pixels on this imaging have been distinguished as far as their frequency and phase are concerned. So when you, now this is the situation now. I selected a slice. Over this slice, suppose this is only a 5 by 5 matrix. Usually when you do MR imaging, you do a very high resolution matrix, 128, 256, 512 by 512 matrix, picture elements are there, which is a very high resolution. Here, for the sake of teaching, I have taken only 5 by 5 matrix. You can see on this image, all the 25 pixels have been distinguished by different phase frequency combinations. So this you can see here in this column, all have same frequency but different phases. Here same frequency, different phases. So I have distinguished each pixel on this slice by different phase and frequency combinations. So this is how you get K-space data. This is the raw data how you get. Then what you are doing when you have, so what you are doing basically, you are applying a frequency encoding gradient, and then one step of phase encoding. You are acquiring one line of data. You can see here one line of data has been acquired. Then when you repeat the experiment, then you acquire the second line. Then keep on repeating, and then you will have all data points acquired in the this K space or in the image space. So this is how you do image acquisition. You apply apply a selection gradient, select a slice, then apply a frequency encoding gradient, and apply one step of phase encoding. So one line of data is covered. Then you increase the phase encoding, take the second line, third line, fourth line, fifth line, depending on number of lines you have on the image matrix what you have selected. So many steps of phase encoding will have to be acquired to acquire the whole data. Then you have this K-space data, and then when you Fourier transform this data, you get an image space, or you can see the image of the brain which has appeared here. So after this K-space data is Fourier transform, you will get a image of the brain or any other organ which you are trying to acquire. And I want to caution here, the K-space data, the raw space data doesn't correspond one-to-one on the image data. They are different because this is in the K-space data. This is a phase frequency data. So when you Fourier transform, only then this becomes a image data which looks like this. So there's no one-to-one correspondence on the K-space and the image data. Now I want to introduce two concepts of to explain further. See, when you apply a 90-degree pulse and when you acquire the signal, the time between these two events is called echo time. Okay, and then when you apply first 90-degree pulse, acquire one Fourier line, and when you have to go for second Fourier line, you have to wait for a period which is called TR. That means the distance between the time between two 90-degree pulses is the TR time. So these TR and TE times are very important for every NMR experiment. So these are very important parameters. So you should know what TE and TR means. TE means when you apply the first 90-degree pulse, and time between first 90-degree pulse and the time of acquisition of the data is called echo time. You are acquiring an echo signal. So this is called echo time. And the time between two 90-degree pulses is called the repetition time or the TR. So this is the convention in MR imaging, and all NMR experiments, whether it's spectroscopy or imaging, they have these two timings, T and TR. And most of the diagnostic imaging, these two parameters are varied to change the contrast of the image. So what are the steps in image formation now? First, you have to excite a spin system of one slice by applying a size selection gradient. You apply a selection gradient and a selective RF excitation pulse. That means by this combination of this selection gradient and radio frequency pulse, one slice will be selected. Then you are applying a phase encoding gradient for a fixed time. Then you are applying a frequency encoding gradient and collect n data points. So one row of data is collected. Then after that, you increase the value of phase encoding gradient. and repeat step from 1 to 3 and perform a 2D Fourier transform of the data to produce an M into N image. Now, what is the time of acquisition for this image? Time of measurement is equal to TR, as you know, that is the distance between two 90-degree pulses, and into phase encoding steps. So if your matrix is 256 by 256, then your acquisition time will be TR multiplied by 256. That means the measurement time is directly proportional to the TR and the number of phase encoding steps. More the phase encoding steps, larger will be imaging time. Lesser the phase encoding steps, lesser will be the imaging time. Same way with the TR also. Then there's one more term which is called number of averages. You know, NMR experiments, NMR is a comparatively a very low sensitivity technique. So many times when the signal to noise ratio is not appropriate, we increase in we repeat the experiments time and again. But most of the imaging experiments are done with one average. But in spectroscopy, it is very normal practice to increase the number of averages or repeat the experiment many times to have a good signal to noise ratio. So this will also affect your measurement time. So if you are taking two averages, the measurement time will double. If you are taking 4 averages, it will become 4 times. So these are the parameters which you have to keep in mind depending on your signal to noise ratio and time of acquisition TR. You have to see how much time you can devote and whether you really need a very large number of phase encoding steps. Okay, so that your measurement time is not very large. So you have to play around with these parameters depending on your specific application. So when you have to perform this experiment, you have to first step is you have to screen the patient for any ferromagnetic materials or any material which can fly out into the magnet. So then you have to position the patient and then use the appropriate coil, receiver coil, which receives the signal. There are different coils for different body parts. So depending on which part of the body you are doing, you will appropriately place the coil. Then you select the pulse sequence and the parameters of the which technique you want to select. Then you will make a first localizer scan, a rough scan, to just have an idea of the anatomy. And then over that scan, you can select the final position of slices and which cuts you want to take, whether you want to take sagittal, coronal, or axial. Then you also do a automatic pre-scan which does the frequency adjustment and transmitter adjustment, 90-degree pulse adjustment, 180-degree adjustment, the receiver tuning, matching, etc. is done during this. So then you can acquire images and then do the post-processing depending on what technique you have used, and then you can archive your data. This is how a MRI image is acquired on a MRI system. Now this in vivo NMR can give you all type of information. If you want to have a anatomical information, which is basically a diagnostic imaging, which you see every nook and corner of the city where people do diagnostic centers, they do MRI for diagnosis. Then there could be a metabolic information. It can give you the biochemical profile or the metabolic profiles in the body and how these reactions are taking place within the body, or it is giving information about the metabolism. Then you can also get information about the functional information. As I said, the functioning of the brain or any other organ, the perfusion, the diffusion processes, the cortical mapping, all sort of thing can also be acquired using this in vivo NMR. So if you look at some of the images, this is a sagittal, image of the brain. You can see from one side of the brain to the other ear. You can see how the beautiful images are produced, and you can see how well the gray matter and the white matter is distinguished in MR. This is the beauty of MR. It has a very excellent, soft tissue contrast. It can distinguish between gray matter and the white matter, which is practically not possible with any other imaging technique. So you can, and this is the best technique to do the spine imaging, and no other imaging modality can show you spine in this like this as it's shown in MR. And you can see there's a disc is pushing the spinal cord at C4 and C5 levels, pushing the cord inside. So this is a condition where we call cervical spondylitis. People complain of the giddiness, and then there's a pain in the arm, upper limbs. This is because of the cervical spondylitis. And if you do a MRI of a spondylitic patient, you can see images will look like this. This disc, the vertebra will be pressing the spinal cord, which is called compression of the nerves, and the person gets pain or the numbness in the upper limbs. So this is a brain tumor imaging. You can see this is a sagittal. First one is a sagittal. You can see a tumor is not so well visualized on T1 sagittal, but T1 also there's a tumor is visualized, and this is a T2 weighted image. Where you can see the tumor looks very clearly vis-a-vis the other regions of the brain. So when you are doing a clinical imaging or the diagnostic imaging, the two set of images, T1 weighted and T2 weighted, what they mean we will discuss a little later. But these are the two minimum set of images which are required to diagnose a patient. And this T1 image gives you anatomical details. You can see the distinction between gray matter and white matter is very well visualized here. But tumor is very much highlighted in T2 weighted image. So T1 weighted image is good for anatomical details, whereas T2 weighted image is very good for giving you pathological information. So this is, and believe me, these two images are from the same patient, same slice, same sequence, but the only thing what has been changed here is TR and TE to look at these images differently. So TR and TE, with the different combination of TR and TE, decide whether the image will be T1 weighted or the T2 weighted. How this is done, we'll discuss when we go for pulse sequences program, pulse sequence lecture. Similarly, this is a venous artifact infarct. This is an infarct in the brain. You can see this is a T1 weighted image. You are seeing a very bright region, and across this region you are seeing also a iso-intense, big area, which is not very well visualized here. But when you take a T2 weighted image of proton density image, you can see how big the area is. There's a fluid accumulation across this lesion, which is small here, which is very well visualized on T2 and proton density image. This is a venous infarct. So this is a very rigorous tumor, which is called GBM, glioblastoma. It's a very, very aggressive tumor. This doesn't let people live more beyond 6 months. Once they are diagnosed, they can't live more than maximum maybe 1 year. So you can see the T1 weighted image shows a good anatomical image, but it is only showing you something is abnormal there. But when you make a T2 weighted image, you can see there's a big tumor which is inside, and there's a lot of fluid outside, which is called edema, which is shown in the blue arrows, and tumor lines are shown in yellow. So what happens, if you don't have this type of picture, the surgeon will not know what is the extent of tumor. He may assume the whole thing is tumor. But once you do a T2 weighted image, you can see tumor is only within the boundaries of the orange arrows. The rest is all fluid or edema across the tumor. So this can be used to calculate the tumor volumes accurately if you have T2 weighted images nicely done. And you can also do multiple times T2 weighted at different echo times, so that only you can see only edema, and tumor T2 will die away. Only edema can be visualized. So you can really very well delineate the edema from the tumor by doing that. So this is a lymphoma, again a tumor. You can see how again T1 weighted is only showing you the anatomy, but it shows you rest of the things also. How big there's a huge fluid accumulation across the tumor, which is very well visualized on T2 weighted image. This is a astrocytoma, again a tumor. You can see T1 weighted. Here the whole thing is this looks like a cystic tumor. So there's no this only T1 is dark and T2 is becoming bright. So there's no iso intensity anywhere else except they are similar looking, except T1 it is dark and T2 it is bright. So it is only it could be a cystic tumor, which is very well visualized on this T2 weighted image. There's a disease called multiple sclerosis. This is very common, not so common in India, but in Western countries. So this is a white matter abnormality, and because of this, so the transmission of information, nerve transmission gets affected because these there's a demyelination of the white metafiber tracts, which are shown as hyperintensity on the images. You can see these different hyperintensity bright lesions on the brain. So this is a typical appearance of multiple sclerosis, which is a very disease which doesn't have any cure. It's a degenerative disease which increases with age and with time. So this is a very beautiful picture of the pituitary gland, and you can see very small, small bright spot in the pituitary gland. You can see which is marked by the yellow arrow. Very small, two small piece, bright spots. There could be pituitary adenomas, which are resectable, or they can be by Karma knife. They can be removed. So the T1 they are not so very well visualized, but T2 is showing these pathologies very well, which you can visualize here. This is a stroke, the brain stroke, and in the left thalamic region, you can see how bright stroke. But this is a diffusion weighted image. This is not T2 plus diffusion weighted image. So you can see there's a stroke. That's what I was telling you yesterday. Diffusion is the only technique which can show you stroke within few minutes of onset. Usually, if you miss this time, we call it a golden hour. If you miss this golden hour, then this region of the brain will be permanently damaged. The neurons will die in this area, and then any function which is corresponding to this area of the brain, the patient will have that paralysis of those functions subsequently. So it is very important to uh, give the medical attention to a person if somebody has got a stroke, and you have to tell your doctor to go for a diffusion, because if you take only T2 weighted image, this may not be even seen on T2 weighted images immediately after the stroke. So diffusion is one which shows you. This is a SOL, space occupying lesion in the left temporal lobe, and you can see the diagnosis. You can see here, this is a T1 weighted, and you can see how brightly this whole thing is being shown over here. So the diagnosis could be high grade glioma or metastatic lesion. This could also be a metastasis in the brain. So this is another case of schwannomas in brain and meningiomas. You can see the bright regions here in this in a 46-year male patient. You can see acoustical schwannomas in the brain. This is again, this is a neurofibromas in the lumbar, dorsolateral spine. You can see these are the bright spots here. You can see which are shown here on the images. See, these type of diagnosis is very difficult to do on any other modality. Only MRI can produce such a wonderful images and show you these minor defects in the spinal cord. So this is you all know sinusitis. These are the sinuses. These are the sinuses, and they are supposed to be a gaseous, only air-filled spaces in the brain near the nasal cavity. So, but they are supposed to be only dark black regions. But there's a fluid accumulation. We see sinusitis. This shows the bright liquid form, accumulation in these areas, and where you have sneezing and headache, and all those things happen to you. These are shown by the red arrows. The maxillary sinusitis is shown in the red arrows. Here down below you are showing a small, maxillary polyps in these spaces, shown by the red arrows here. Small polyps which have happened in the nasal cavity. So very beautifully they can be visualized in the MR images. So this is a very interesting appearance of the tuberculosis of the brain, and believe me, before the MRI arrived on the diagnostic imaging, the most of these patients were unattended. They were not. They were used to get paralyzed. They used to get functionally deficit, but nobody knows Nobody knew what is happening with these patients. Same thing happened with neurocystic sarcosis. There are some these small lesions in the brain, but they were not visualized by any other technique. So these patients were treated by chance. They will treat for different disease and see which treatment will fit them best. But with the advent of MRI techniques, because it is a very characteristic appearance of tuberculosis brain. It is a bright ring with a dark scolex in between, in the center. It's very prominent appearance of tuberculosis of the brain. So this is the imaging of the knee, and most of the people will tell you that they have a whole body MRI system. But that doesn't mean that you put a body and you get all images from all sections of the body. The whole body means you can do any part of the body on this MRI. It doesn't mean you put a body and you get all images from head to toe. You have to select your region and take this to the center of the magnet and then to perform the imaging. So this is now imaging of the knee. You can see here this is a bright region like his, which is shown by I am moving my cursor. This is a synovial fluid which is accumulated in the knee joint, and most of the people in elderly age, they have difficulty in walking, pain in the knee, and mostly ladies get this quite often beyond the age of 40-45. They complain of pain in the knee and difficulty in walking. So this is a inflammation, and then there is a accumulation of synovial fluid in the knee joint, which doctor can put a needle and take it out, or by the use of medicine this can be dried out so that the pain and the pain can be relieved from the patient. So very beautifully it can be seen how synovial fluid is accumulated in the knee joint. This is the breast MRI, and on the left hand side, usually I told you last time, most of the times you do not give any contrast agent in MRI, but sometimes when the doctor is in doubt, he is suspecting something and he doesn't want to miss that. So this was a pre-contrast MRI where doctor suspected something here but was not very sure about it. So they gave a gadolinium contrast agent, and then you can see suddenly this lesion brightened up. You can see a small lesion in the breast which has been highlighted by the contrast agent, which was not visualized on the pre-contrast images. This is a brachial plexus on the shoulder joint. You can see these are preganglionic injury. You can see here with the red arrows is the injury of the plexus and nerves, and you can see on the blue arrow are the healthy nerves. You can see the difference in the two sides. This is a healthy or the normal nerve, and you can see how the brachial plexus nerve is affected by the injury. Similar way here, on the right sided, and you can see this is a normal, blue is a normal nerve, and red is the affected shoulder. You can see how beautifully these can be visualized on the MRI. This is another, this is a shoulder joint. You can again see similar, as I showed you in the brain, similar looking lesion in the shoulder joint. This is a tuberculosis of the shoulder, tubercular right shoulder joint. You can see again a very bright ring and with a dark scolex in the center. Very, very typical appearance of a tuberculoma in the shoulder. So this is a breast scanning again. Now there's a tumor, but we do not know whether this is a malignant or a benign tumor. So you do a perfusion scan, you inject a contrast agent, and there's an appearance here. You see something is wrong here in this region of the breast, but you are not very sure whether this tumor is malignant or benign. So you do spectroscopy, which we will discuss later. I don't want to confuse you with this spectra first, but here I can show you a normal breast, a normal lesion, region of the breast will take this much of time for this contrast agent to reach to the peak. So this peak should have been actually on this line here, but there's an early wash-in. That means the tumors are hypervasculature. They take blood very fast. They take too much of blood, and they take too much because they need a lot of energy. They suck a lot of blood from the bloodstream. So you can see in this region, there's a early wash-in. That means this peak is much before this line, this time point, and then it is washed out before this time point itself. So when it is a situation like this, early wash-in and early washout, it is typical characteristic of a malignant tumor. So you can say based on this perfusion scan, you can say whether the tumor is benign or the malignant. This is a dynamic study. You inject a contrast and measure the time when this contrast region contrast reaches this point. Then plot this graph. You can see this graph in red line. It is much before than the actual transit time. So that means it is an early wash-in and early washout. So this means it is a malignant tumor. So this is a the common bile duct in the liver, CBD. You can see the small stones, these black, red shown in red. This black. This is MRCP using MR. You are doing angiogram. You can see the stone here with the red arrow, and here also you are able to see in the coronal section. You see a stone in the CBD. So this is a big tumor in the liver metastasis. You can see this is a two images in the same sections. You can see how big the metastatic. So this is all the liver is affected by the cancer, and this may be a fag end of the patient's life. The whole tumor is metastasized by the cancer. So this is a small extradural enhancing lesion you can see here. This is because of the disc fragment which has caused infection in this region. You can see this is a infective lesion seen over the images in different orientations. So this is a bone cyst you can see here. Which is again visualized by MRI very nicely. This is a coronal slice, this is a sagittal slice, and these are the axial slice. You can see how beautifully this lesion, bone cyst. Again, since it is bright in T2, so it is a cystic lesion, and you see the T1 is showing a dark, not so bright lesion here. So this is a cystic lesion, which is shown by T1 and T2 weighted images combination. This is a again lumbosacral spine of a old patient. You can see this disc is pushing the lower spine, spinal cord of the patient, and this will cause lumbar spondylitis, and this will affect the lower limbs of the patient. They will again have numbness and pain in the lower limbs. When you see you can see how many levels. 3 levels it is pushing the spinal cord, is actually pushing inside. So it's pushing the nerves, which is causing the pain in the lower limbs, because these nerves are connected to the lower limbs, and then they will have pain and then difficulty in walking. This is again a pot spine. You can see using MRI, you can take the whole spine in one shot. So the whole spine has been covered in one shot. You can see there's a disc prolapse here. One disc is damaged completely because of the injury, and it is pushing the cord inside. So this patient is compressing the cord completely, and then it is shown over here. And it is because of this compression and damage. There's a lot of abscess in the spinal cord area. You see bright fluid accumulated on the both sides of the spinal cord. And then tractography, the diffusion tensor also shows this color, the blue tracts which are coming. They are changing because here the damage has happened. So there's no water diffusion beyond this point, as it should have been. It should have been the whole thing. Should have been the blue color, exactly the same blue color all throughout. But because of this disc prolapse, diffusion is affected here in this region, which is also shown by diffusion tensor imaging, diffusion tractography. This is a very congenital disease, genochondromatosis, and this happens in long bones. You can see all these bones, joints, bright regions. They are affected in this patient, and this can run in families because this is a genetic disorder. And in this case, also we saw a close correlation having the similar appearance on the MR images on the long bones, these bright lesions on the bones. So this is a neurogenic bladder. This is a urine bladder, you can see, and these are the ureters, and this coming you can see the very special appearance because of the neurogenic bladder. It's like a Christmas tree appearance on the urinary bladder here because of the cancer. Then these are the multiple. This is a MRI of the pelvis, and you can see fibroids, small fibroids in the pelvic region. In the uterine, uterus fibroids are there, shown in the red arrows here. So you can also do angiography. The conventional angiographies are very, expensive, and they can be, very, they're invasive, and patient can sometimes have, complications while angiography is done using conventional methods. But here you can do a conventional angiography by MRI. You can see this is the heart which is pumping the blood into these are the carotid arteries which carry blood to the brain. This is a circle of Willis, and you can see how beautifully these vessels which carry blood to the brain can be visualized nicely. And these are the carotids and basilar arteries and the vertebral arteries, all brain, different parts of the brain. These arteries supply blood, and some of the regions here you can see there's some these arteries are blocked. Atherosclerosis has happened. There's a narrowing of these somewhere, some places. You can very well visualize where there's a constriction. Like here is a constriction in the artery, which you can see very well here by this arrow, and here also you can see these constrictions. So these patients may have will get less blood in certain areas of the brain, and can also cause the stroke because of the limitation of the blood supply to the brain, because brain is a very highly demanding organ as far as the blood and oxygen and glucose is concerned. So in fractions, few seconds of stoppage of blood can cause damage to the brain very severely. This is again a complete angiogram. This is called peripheral angiogram. You can see from the almost from the chest region to the toe area. You can do the angiography, and you can see different femoral arteries and then suprafemoral arteries. You can see all these regions, the arteries, very nicely using this angiography technique. You can also do a MRI of the heart. You can see the left ventricle and the right ventricle, and then 4 chambers of the heart. You can also calculate the different parameter like ejection fraction and ventricular wall motion by playing these images in the cine mode. You can see the ventricular motion as well, and a very nice technique to look at heart and myocardium. This is a after you acquire the image, you can reconstruct the images, and this is a reconstruction of the from the air imaging. You have reconstructed the internal auditory canal. See how beautifully this is actually a picture of the if you take a photograph of the internal auditory canal, you will see image like this exactly showing so beautifully. And then the modern MRI systems, as I said, you can see there are kidneys, the renal arteries, and then how these blood arteries are going down to the different regions of the brain. You can also do a this is the tractography which I told you. By diffusion tensor image, you can show the white matter fiber tracts, how they are connected and which direction they are oriented. And then you can do a functional MRI. You can show the functional areas also, these tracts, how these tracts are connected to the different eloquent areas in the brain by combination of the bold fMRI and the DTI sequences. So this is a people who know about positive emission tomography scan. It shows that is a very good modality to show you the metastatic lesions in the whole body. When a patient has a cancer, there could be a spread of cancer in the whole body. So the PET scan is done. Usually, all of you must be knowing about PET scan. So MRI is also trying to catch up, making images like a whole body PET scan, which it can show metastasis over the different regions of the body. So that PET scan, which is more of radioisotopic intervention and then very expensive, the MRI can be utilized to look at the metastatic lesions in the different parts of the body. So I think this is my last slide on the imaging part, and we have 2-3 minutes. If you want, we can have some discussions, because or we can move on to the next part of the study. But I think I will like to have questions for 2-3 minutes, so that we can wrap this lecture up. Hello.
Yes, Professor.
Yeah.
So, what today he is going? Okay, participants, if you have any doubt, can ask Professor Khushuk if you have any doubt. The thing is that the participants, they rarely interact. That is a thing, or observation. But sir, I just want to know how you image heart, means how it is done experimentally, because you have already a system like you have the ribs, the muscle, how you select the image of the organ which is located.
I told you, you can, the beauty of MRI is you can cut the slices in any plane, any
Okay.
orientation. And for the people who are in nuclear medicine, they know heart is best visualized in LA 30 degrees angle, So
Okay,
you
okay.
can create, you can make a, like I said, you can make sagittal, coronal and axial slices. It is also possible to create paraxial, paracoronal and parasagittal slices. So you know the orientation of heart, you can cut in that orientation at that angle and have very nice picturization of the of the heart. And then you can do a cine mode. You can do a, like in nuclear medicine you have gated study where you acquire the heart and in the different phases of the cardiac cycle. Similarly, here you can ECG gate and synchronize your measurement with the ECG gating, so that you can acquire images at different phases of the cardiac cycle. And then you have those images. You can play them in cine mode and see how the left ventricle and the heart is pumping blood, and what is the how much blood is pumping, what is the ejection fraction, what is the left ventricle volume, what is the when it is systolic and diastolic phases, what is the amount of blood they are having, what is the volume of the ventricles. All this can be calculated by having a proper orientation of these images, which can be very, very easily done by MRI.
Any question from the participants? Okay, sir, I think the participants are not keen to ask any question. Probably they may take some time to understand what you are teaching. And I request participant to contact Professor by email. I think he has already given you the email. Okay, sir. Then I think we can stop it here now.
Okay, thank you.
Thank you, sir. Thank you.
Thank you so much.
Thank you. So we can now your next class will be on Friday.
Yeah, Friday.
Okay,
Fine.
sir. Then thank you very much, sir.
Thank you so much.
Thank you.